Now let's discuss the mechanism of action of individual drugs which block the sodium channels. These are phenytoin, carbamazepine, felbamate, lamotrigine, and valproic acid. These all block sodium channels. Next are barbiturates, and we now know that phenobarbital, meflobarbital, and primidone are under the barbiturates heading. What barbiturates do? They prolong the action of GABA, which means there is prolonged chloride channel opening. Benzodiazepines, what they do, they increases the frequency of GABA mediated chloride channels opening. This means that this also opens the chloride channels. Sodium valproate, what sodium valproate do, that it enhances the GABA transmission. Number 2, it blocks voltage dependent sodium channels, and thirdly, they also block the T-type calcium channels. Ethosuximide is an other drug which blocks the T-type calcium channels. The newer anti-epileptic drugs, vigabatrin, irreversibly inhibits GABA transaminase. The tigabine, which interferes with GABA uptake. Topiramate blocks voltage dependent sodium channels. Also, it increases the frequency at which the GABA opens chloride channels. In addition to this, topiramate antagonizes the action of glutamate. The action of topiramate is yet on other side from the benzodiazepine. Gabapentin interferes with GABA reuptake. Now let's discuss the individual drugs under the headings of mechanism of actions, which we discussed before, their pharmacokinetics, their side effects, and their drug interactions. The first one is phenytoin. Phenytoin is metabolized in liver by two mechanisms. First one, hydroxylation and glucuronide conjugation. Hydroxylation is phase 1 reaction and glucuronide conjugation is phase 2 reaction. Phenytoin basically shows mixed order behavior at therapeutic concentration. A small increase in dose may lead to a large increase in drug concentration. The time to reach the steady state is often longer than 2 weeks. Phenytoin, if administered through oral route, its absorption is very slow. It binds with protein with the capacity of 80 to 90%. When we talk about the adverse effects, it has so many side effects. Common side effects include nausea, stomachache, loss of appetite, poor coordination, hirsutism, and gum hypertrophy. Potential serious side effects include sleepiness, liver problems, bone marrow suppression, low blood pressure, and toxic epidermal necrolysis. There is evidence that use of phenytoin during pregnancy results in abnormalities in the baby. Its use appears to be safe during breastfeeding. Its effects on heart and blood vessels results in severe low blood pressure and abnormal heart rhythm, which can be seen with rapid infusion of intravenous phenytoin. Neurological side effects at therapeutic doses are that phenytoin may produce nystagmus. At toxic doses, patient experience vertical nystagmus, double vision, sedation, slurred speech, tremors, and cerebellar ataxia. What if phenytoin is stopped abruptly? This may result in increased seizure frequency, which might lead to status epilepticus. Phenytoin inhibits intestinal conjugase, thereby causing folate deficiency, which might lead to megaloblastic anemia. Other potential side effects are agranulocytosis, aplastic anemia, decreased WBC count, and low platelet count. Phenytoin is a known teratogen. It consists of craniofacial abnormalities and mental retardation of the baby. This syndrome resembles the fetal alcohol syndrome. So that is why this is also called fetal hydantoin syndrome. Another side effect of phenytoin is overgrowth of the gums, also called gingival enlargement. Probably this is due to folate deficiency. In skin, it causes Steven-Johnson syndrome, hypertrichosis, and coarsening of facial features can be seen. Phenytoin has been known to cause drug-induced lupus. In bone, chronic phenytoin use has been associated with decreased bone density, which might lead to increased bone fractures. As phenytoin induces metabolizing enzymes in the liver, this leads to increased metabolism of vitamin D. The result is decreased vitamin D levels and the resultant vitamin D deficiency.